We're going to talk about what service options exist for individuals aging out of covered youth services and how to plan and consider and what is next in this journey. So what is autism? Autism is a developmental disability, a lifelong brain disorder. It is defined by behavior. So there's no lab tests, no image studying, and there's no medicine or treatment that cures it. There is a genetic component, but in most cases the cause is unknown at this time. It can also occur with a genetic disorder such as Down syndrome or Fragile X. So there was changes in the diagnostic criteria for autism spectrum disorder, so this is just a visual from the DSM-5. So originally we had autistic disorder, PDD-NOS, and Asperger's syndrome. Now it's all combined to one and is just the autistic disorder. So from nonverbal individuals with stereotypes and behavior problems, one quote that I'm sure a lot of you have heard from Dr. Stephen Shore is, if you have met one person with ASD, you have only met one person with ASD. To high-functioning individuals who can't switch subjects to conversations and do not wait for you to add to it, each person's presentation is individualized, yet all qualify under ASD. So these are just some facts and numbers. 1 in 2000, in 1990, were diagnosed with ASD, and now it's around 1 in 68 in 2012. 1 in 68, so there's a 1.4% of the population has ASD. The population in Massachusetts, there's 6.75 million, so that is 90,000 people with autism spectrum disorder. 500,000 children with ASD in the US will become adults with ASD in the next decade. ASD is about 4.5 times more common among boys than it is with girls. And the total cost in millions, so medical, educational costs, loss, and parent wages.
We're actually going to switch back and forth quite a bit, so bear with us and thank you for your flexibility. And just in case people are wondering, my name is Julie O'Brien. I work at the Lurie Center, and I'm proud to co-present with Justine from OPG. I'm doing a little bit of consultative work, so I'm still at the Lurie Center. I don't want people to get confused about that. A lot of the information we're talking about autism, I'm sure you guys have heard this, it's not new. I thought it would be a nice way to give a little bit of primer before we get into some of the services and resources. Did you know about 60% of children with autism have an intellectual disability? I know a lot of times in these today, especially, and in some of our presentations later on, we're going to talk about different levels of functioning, and a lot of the coaching services tend to be geared more towards the higher cognitive verbal functioning folks. But I don't want people to, we don't want people to forget that the large spectrum and sort of just globally there's a lot of variability on the spectrum. So those who have intellectual disability, we can't forget that subgroup. 50% develop seizures. We have talked a lot about and heard a lot about the medical comorbidity, and I think that's something that we need to realize and consider and keep remembering that a lot of our kids, no matter where they are on the spectrum, may have serious medical conditions. Seizures occur typically less than 5 years old or during puberty, but then there's a subset that seizures begin later on as well. And a lot of our individuals need to see neurologists as a specialty lifelong. 40% will never learn to speak, but will learn to communicate with pictures and electronic devices, thankfully. So, next slide. Again, lack of eye contact and or facial expression are common. The language in children who are verbal, atypical rate, rhythm and tone, scripted phrases. I'm sure, again, if you have children or work with children, individuals, this is not surprising or anything new. Echoing what I said, echolalia, maybe repeating something that they've seen in a movie, or it's also called scripting or delayed echolalia. Pronoun reversals using you instead of me. One of the reasons, again, we'll talk about, probably not, in school-age children can receive speech and language in school. We can receive it outside in clinics. but it really, our kids require lifelong interventions, speech, language, especially. This is an innate disability that affects social communication. So I just want people to remember that if we're talking about coaching and other services and supports, wraparound supports, which I'll talk more about specifically, we can't forget that we have to continue to teach our kids in the speech and communication domain and social domain. Frank this morning, the autism daddy, I don't know if he's here now, but I loved that he spoke about sort of the titles or profiles that we use, different language, higher cog, verbal functioning. We use these terms loosely. We're not trying to, label anybody or be disrespectful at all. We all deserve respect, and these individuals certainly deserve respect. So when we say high cog, high verbal, high functioning versus lower functioning, I think we're just trying to describe the spectrum and sort of, focus in on the folks that we know and we understand. Average to above average verbal and cognitive skills, that's, what we consider those who have former Asperger's syndrome. Lack of clinically significant delay in spoken receptive language, self-help skills, but certainly the way the language is used and understood is affected, considered milder end of the spectrum again versus more severe end. Social differences, communication differences, restricted patterns of interest, behavior, and activities. Again, nothing new to what we know. Am I doing this or you? Sorry about that. And this, again, individuals with high cog, high functioning, former Asperger's, some of the main areas that our kids struggle with are individuals: social cognition, theory of mind, lack of perspective taking, understanding others, realizing what others are thinking or feeling. I have a perfect example. I have 2 children on the autism spectrum, one considered on the milder end, one on the more severe end. And these skills can be taught, I believe, and it's constant, it's lifelong. My son, when he was younger, he would go up the stairs first and try to get into the house to go find his Disney movie. And the door would shut behind him and we'd say, oh yeah, thanks Kev, I'm here too. That's that theory of mind or lack of perspective taking. Well, he now is a door holder. He's amazing. He holds doors for us. He holds doors in the community and generalizes, and I don't know when and where he learned that, but he did, and he's the best. He should work at a hotel and be a doorman. He's amazing. Central coherence, executive functioning, nonverbal communication, these are all areas that are significant with our kids with autism and need to be taught explicitly and directly. I think the executive functioning in particular, we find kids, this is struggling with planning and focusing and shifting set and being able to be flexible. And, I think many times that's probably, this is my personal opinion, just the real problem with our kids struggle with to get up out of bed every day and get ready for their day and get out the door. How do you teach executive functioning? I wish we could wave a magic wand and have it be available in our kids' brains, something we take advantage or take for granted. But I think this is a piece where when we talk about services and coaching and explicit teaching is something we need to focus on. Where are we? All right, so again, the lower functioning, former autistic disorder, those who are more severe, more challenged, they have typically lesser cognitive or lower skills. Again, certainly teachable. Slower learners, certainly teachable, given the right modality, which Justine's going to talk to you a little more about. Clinically significant delay in spoken or receptive language, self-help skills. Again, the lower end of the spectrum. Core main areas are requiring intervention generally in social communication, restricted patterns of interest. They require more specialized educational supports in school. A lot of our students, when they're in school, wonderfully are able to stay in inclusion and get the supports they need to remain being able to be taught in their communities. I think that's really important. But many of our guys need to go to collaboratives or private schools for more specific intervention. And a lot of these young men and women stay in school till 22, luckily. And others, maybe not. Maybe they age out and they earn their certificate and can move on to higher ed learning. Require more intensive behavior support. ABA programs, which Justine will talk about, they require more specialized communication, AAC devices, iPads, dedicated devices. Many of these guys have more medical complications, seizures and GI, and difficulty with daily living. I get to stay up here a lot, right? All right, this is one of the slides that I love, and I think because it shows us what we're dealing with. And my colleague, Dr. Curie, spoke this morning. Many of you probably listened that this is very real. This comorbidity is real, and I think we've all heard about it today, that autism and autism spectrum disorder overlaps and has coexisting comorbidities, mental health issues particularly, some medical as well. Autism and, anxiety and depression and OCD-like features are really, really, I don't even know if these numbers are really accurate. Honestly, I think they're a lot higher. These are significantly impact the functioning of our children, teens, and young adults and adults, to the point where especially depression and anxiety really rules. And so many of we see these folks at the Lurie Center, and they're treated by psychopharm, and a lot of times successfully, thankfully, but our guys need wraparound services. I heard the Bridgewell talk this morning, the clinical talk about the newly diagnosed eligible folks with autism living in the community, and many of them are seeing psychiatrists and on meds. Many of them need counseling or on wait lists for counseling, for the mood, anxiety, and other syndromes. So I really think that this is something that is important. We see it. I see it every day, and it's really impacting families and our kids. So we need more practitioners to focus and specialize in this area. Many of you guys live this, so I'm not telling you anything that you don't know. All right, I think I have one more slide before treatment. Okay. So again, some of the common treatments that we know: early intervention, communication, OT and PT, behavioral. Behavior improves with better communication. I think, again, communication is so key, no matter if it's adaptive communication, total communication, social communication, pragmatics. I think that our individuals that I've met with and learned from have trouble identifying their feelings and telling us and expressing themselves. So this is a huge, huge need, and we need to continue to provide this social skills training. Psychopharm I just talked about, to address maladaptive behaviors and emotional dysregulation, and attend to medical conditions, if any. I think you're on now.
All right, so what is applied behavior analysis? So applied behavior analysis is often known as ABA in today's world. It's the use of these techniques and principles to bring about meaningful and positive changes in behavior. Behavior analysis focuses on the principles that explain how learning takes place. So positive reinforcement is one such principle. When a behavior is followed by some sort of reward, the behavior is most likely to be repeated. So through decades of research, the field of ABA has developed many techniques for increasing useful behaviors and reducing those that may cause harm and interfering with learning. These techniques can be used in structured situations, such as a classroom setting, as well as in everyday situations such as family time, dinner time, neighborhood playground, or out in the community. I think one thing that's important to touch upon is, I know when the term ABA comes up, one person can think of it differently as somebody else. So it's important. ABA can be used in the classroom, sitting down in one-to-one with a teacher, in a group setting with other individuals, outside on the playground with friends. It can be used across the board. A number of recent studies confirms that ABA techniques are effective for building important life skills in teens and adults with autism. Many comprehensive autism support programs for adults employ and combine ABA techniques to help individuals transition successfully into independent living and employment. So some established interventions for adults. So the only intervention to be identified as an established for individuals ages 22 years and older is behavioral interventions at this time. So this consists of ABA interventions to increase adaptive behaviors and decrease the challenging behaviors. Emerging interventions for adults, so the vocational training package. So vocational training packages for individuals is really individualized to help with a trade or a craft, provide students with hands-on instruction, and for a lot of individuals with autism, that hands-on instruction, that modeling in the moment is where we learn best. The unestablished interventions are those in which have little or no evidence in scientific literature that these are effective or ineffective at this time for adults. So that consists of modeling, music therapy, sensory integration. So effective ABA interventions for autism is not that typical one-size-fits-all. Everything should be individualized. So one ABA program for one individual will look totally different than a program for another individual, and I think that's very important to remember. So in a good program, so the therapist should always be planning and conducting ongoing assessments of skills. The therapist uses a variety of behavior procedures, some of which are directed by the instructors and some are initiated by the learner. Parents and other family members and caregivers receive training so they can support and learn the skill, practice the skill, and be able to consistently use this across settings. That's something important. A lot of families have ABA come into their home. So you have an individual working with a therapist one-on-one for say 2 hours a week, 2 hours at a time. It's really important for family members, whether it be siblings too, to also get involved and learn those skills so that when the ABA therapist isn't there, that consistency can carry over. Learner's Day is structured to provide many opportunities, both planned and naturally occurring, to acquire and practice the skills in both structured and unstructured settings. So a lot of learners learn best through the natural teaching, so incidentally throughout the day. So that's also another key point in why parents should also be really involved in programming. The learner receives an abundance of positive reinforcement for demonstrating useful skills and socially appropriate behaviors. The emphasis is on positive social interactions and enjoyable learning. So the more positive reinforcement for a behavior you want to see, the more likely that you're going to continue to see it. The learner should receive no reinforcement for behaviors that pose harm or prevent learning. So these are some ABA teaching techniques. Literature shows positive effects on behavioral approaches with children with disabilities. So the two effective learning strategies are DDT, which is known as Discrete trial teaching, and the naturalistic teaching, which is also known as incidental teaching. So it's recommended to blend both of these together. So you want to start with DTT to just establish a good learner, and to use those to use the incidental teaching to train, and also you want to generalize the skill. So if an individual only learns a skill in one setting, that's not going to, so if an individual is working with somebody in the home on one skill, then you're out in the community, you really want to be able to generalize that skill across multiple settings. So discrete trial training is the understanding that the practice helps the child master a skill. It's a structured therapy that uses a one-to-one teaching method and involves intensive learning for specific behaviors. Incidental teaching is the understanding that it's important to give real-life meaning to a skill to a child. It includes a focus on teaching a skill in a setting where your child just naturally uses them. Using a child's natural everyday environment in therapy can help increase and transfer the skill to everyday situations and help generalize them. Verbal behavior is similar to discrete trial training in that it's a structured, intensive one-to-one therapy. It differs from discrete trial in that it's designed to motivate the child to learn language by developing a connection between a word and its meaning. So for an example, teaching a word or label needs to include how to use them functionally. So what is this? It's a cup. What do you want the cup for? Drinking. What do you drink out of a cup? So it really puts everything all together in perspective for the individual. So modeling is a form of prompting. It provides a visual example of what is expected in a task by having individuals see the task before it's performed. It can also help the individual see the sequence of steps in a task. So for example, if a student learns the actions to a song first by it being demonstrated by an adult. Also that's for adults in the home, even daily living skills such as emptying a dishwasher, doing the dishes, brushing your teeth. So having that model first is really helpful for a lot of individuals. And pivotal response training is also incidental. It's loosely structured intervention that relies on naturally occurring teaching opportunities and consequences. So there's 4 pivotal areas that have been identified. So motivation, child self-initiation, self-management, and responsiveness to multiple cues. So transition. What do we do, where do we go, and who do we ask? So this is a question a lot of parents are having when it comes to this point in the child's life. So transition is a long process that involves many steps, people, agencies to prepare students with disabilities for the shift from high school to adult life. It's supposed to start by the age of 12 in the healthcare system and formally begins at the age of 14 in the school system. So the transition process should really involves the parent, child, the IEP team, any private treatment team members that they're, any private treatment that they're receiving, medical providers, and community agencies. And overall, transition is creating the child's life for 18 to 20 or 22 and thereafter. So why and how do you plan? So nothing's going to happen automatically. So you need to planning for your child is necessary. So you want to create a team and you want to have a captain. You want to have somebody that's going to be the leader of your team, that's going to be your person of contact to go to. Whether it's a care coordinator, whether it's you, the parent yourself, if you have an educational advocate or a consultant, you really want to have one person to be that captain or that contractor. In the end, planning will help you and your child achieve his or her goals.
I love that previous slide because I've seen many of those faces with the parents in my work at Lurie. All right, so to continue on transition, I just gotta get to my right notes here. I'm gonna go to the next one. All right, so I use these circles a lot, and I think largely because I'm visual, a visual learner, and it really helps to explain and identify the areas in not only our kids' lives, but all of our lives, medical, mental health, different therapies, recreation, housing, public benefits, social skills, behavioral. Our kids need wraparound supports, and we need an action plan. We need a start, and we need to figure out what's in place and how to get what we need. So, and it's some of these circles pop up and become priorities in certain areas, in certain times. So again, I use this as a reference when I work with families at the Lurie Center, and it can be really helpful to create then an action plan. Okay, so go to the next one. All right, accessing services. This is really why we're here. What's out there and how do you access it? What's important to consider? The age of your children. We can get different services at different ages. Of course, when our kids are younger, early intervention, our kids are in school age from 3 to 22 ideally, or when they graduate, they're under the school district and the mandates of special education. What happens when they age out? Diagnosis or medical necessity. I do this a lot at Lurie, and our nursing department does as well. Letters of medical necessity to access insurance, services through insurance. Letters of medical necessity sometimes to go to the state agencies to advocate for services under health and safety. So that's a really big one to know, where your family lives. We all know, and many of us are here from across the state, some services, there are more services in certain parts of the state, maybe not so much in central western Mass, but then maybe there's more agencies here around Metro Boston. And I hope that changes. I work with people from across the state, not only Massachusetts, but other states as well. It's different, unfortunately. And so I'm only as good, I always say this is my mantra at work, I'm only as good as what's out there or what I know. And I know, unfortunately, this is true, many families move. They move here to Massachusetts because maybe their state doesn't provide what they need for their now young adult who is aged out. Some families move towards Eastern Mass. Family resources, this is a reality as well. I talk a lot about buckets of funding and cost sharing, getting money, and there's another slide later on. I'll talk about the different funding sources because not many of us can afford to pay out of pocket for everything and all things. But I think it is a reality that family resources, there are some things that insurance or the state doesn't reimburse for, so private funding has to be come into play. Insurance, I just talked about that. Medical and behavioral mental health, primary versus secondary. I think the reality is no matter if you have a private funded insurance or state funded, Mass Health, Medicaid. And by the way, Terry Farrell's talking right now, so if you want to know more about this, we won't be offended if you run and leave and see Terry, because we are lucky in this state that we have the Autism Insurance Resource Center, and I send so many people to them because they are the technical assistant folks. They have their finger on the pulse. They know what's going on with Mass Health and the Health Connector. So I don't know everything about that, so I do send them. And there's ways. It's not always a good news, but I think the more you know about insurance and how to cost share, how to access reimbursement through out-of-network and advocate. I've heard some more positives than I've heard negatives. Ability to advocate, that's huge. We all constantly advocate as parents. We are constantly trying to find advocates in the community, whether they're legal experts or folks that know how to navigate these different systems. It's a constant hat we wear as parents and professionals, so I won't tell you that that's going to change. It's not going to change. Obviously, that's why you guys are here, to learn more so you can navigate better for your kids. Culture, ability to communicate and understand. I think this is a real important piece that I've seen at our clinic, which is part of Mass General. We have many families that need to learn the services in their own language, and oftentimes our parents are ESL. So we have interpreters, I constantly try to find folks in the community that can help with things like guardianship or special education attorneys that speak more than one language. But I think culture is a big piece, and a lot of times folks in different cultures don't know how to advocate, don't know how to access. So we have to be cognizant of that. School districts, and then willingness of your person, your child, to be able to want to work or have a meaningful life. I think many of our kids do. They just don't know how to do it. Some of our kids do a better job and they're motivated, and I love that. I love to hear that. But we're here because many of our kids have these challenges. How can we make it easier for you? Okay, the next slide. So Dr. Lisa Nowinski, who's a neuropsychologist, one of my colleagues at work and is a champion. She's really great at what she does. We created this sort of snapshot tricks, different, what do we call them, sort of top transition tips. Again, with my circles, I'm always about circles. And I think it's helpful because it highlights some of the areas that we can focus on during the transition years, and some of the specific tips. And so I'm not going to go into this too much. There is, and I can get you a handout if you can't read it. I can send you it I'll give you my email, or you can email me. Healthcare, begin discussions with your pediatrician about transitioning. I don't know how many of you have been able to successfully transition your young adult to an adult pediatrician, or maybe you're lucky and you have a family care provider, a family doctor. This is a huge need, and it's important to find an adult practitioner that gets it, that is open-minded and can help, because as I heard in the first talk, and I didn't realize it, many of our young adults have multiple medical issues, and at early ages. So we need pediatricians willing to stay on as long as possible, but then adult providers that can comfortably work with our kids lifelong. Education, we need to know about transition evaluations and assessments, because how do you create goals if you don't have assessments? You got to start somewhere. And I really strongly feel that assessments can happen every year, really. Starting at age 14, the transition planning form is something that our kids' IEPs must really count on to look at action plans and to really plan. So if you have children between the ages of 14 and 20, 21, and you haven't gone down this road yet, I strongly advise you to get in touch with an advocate or go to a transition, a different talk about that specific piece. Legal public benefits, I know Annette Hines spoke today. Very, very important to attend webinars, workshops with special needs attorneys to learn about guardianship, to learn about other options other than guardianship, which is decision making when your child or children are emancipated. Finding out what SSI is, supplemental security income, and how that's important as a money to pay for housing and living costs when your child is over the age of 18, and independent living skills. All right, next slide. Building timelines and checklists. Timelines and checklists, really important. This is an example that Dr. Nowinski and I put together, and it's actually consistent with the one that the ARC has. So ARC Mass has a timeline that we don't have available, but you can Google it. Very similar, it talks just to different ages and focuses on sort of what you could be doing at that age, Between the ages of 16 and 18, for example, very important to really think about guardianship and applying for public benefits, adult state agency eligibility, SSI. I talk about this all the time at work and guide families. So, and there's information out there in all these areas. But the other checklist I think that is important to know about is the Turning 18 checklist. If you haven't seen it, Autism Housing Pathways has that. Kathy's here and she has copies, Kathy Boyle. So we share that. A lot of these resources, you don't have to recreate the wheel, you just share them.
So during the transition process, who is involved? So students should be actively involved in their meetings and should aim to run their meetings toward the end of their high school years. This is so important to have them involved because they're going to be making their own vision statements, coming up with their goals for social and independent living and their post-secondary education. Also, any person who plays a role in the student's transition from high school to adult life can participate in the student's transition planning and the IEP meeting. So the more people that are involved and that can help the individual, the better. The student needs services after high school. Those of DDS or MRC, a representative from these agencies, can also attend the meetings once the eligibility is determined. So these are just two examples of vision statements for young adults who are in the transition process. So Sally. So this is what Sally, her vision statement, what she came up with. So Sally would like to have a paid part-time job when she leaves school at age 22. She is interested in possibly attending a program while she is not at work. She would like to live with family after finishing school, but be more independent with daily living skills and self-care tasks. She would like to continue to participate in activities she enjoys, like Best Buddies and going to the YMCA. So that her vision statement is more of a social and independent living, whereas Joe would like to go to college someday and work in the healthcare field. He would like to live in a house with a roommate or spouse and continue doing recreational activities that he likes to do with friends. Overall, John's team would like to see him continue to grow academically, socially, and emotionally. So these are some of the transition goals that the team has come up with. So for Joe, he will research specific post-secondary educational choices, so different colleges that he would like to attend, include available academic support for specific programs of study, and determining 3 reasonable options. Joe will demonstrate the knowledge of the college admission requirements by verbally describing these requirements and identifying admission deadlines. And Joe will be able to report 3 possible occupations for part-time employment based on the results of the career assessments. So Sally will take an active role in planning and participating in her next IEP meeting. Sally will complete a blank number of chores at home without prompts. Sally will identify her best learning styles, strengths, and weaknesses. Sally will develop strategies for effective communication skills with others. Sally will advocate for herself with unfamiliar peers and adults. And Sally will use assertive behavior with negative peer pressure with a group of typical peers. These are just some examples of some transition goals. So what can you do now? So it is vital for student success for them to become invested in their education. If they're not invested, then moving forward, it's not going to be productive. In understanding and knowing their strengths and weaknesses and be able to communicate them to others. These skills need to be developed as early as possible. So I think just with the transition process, the earlier the better is definitely key. So self-determination, allowing individuals to make their own choices, having them at meetings is going to allow them to express their feelings, express what they want and what they want to see in their future. Encourage goal settings, have them come up with their goals and encourage them to continue to be independent. Independence is key. Self-advocacy, so teaching individuals about his or her own disability and encourage him or her to speak up and stand up for themselves.
I think that's so important, that slide. I think self-preservation and choice is so important, and we need to continue to help our young adults realize their strength, islands of competence, and help them understand that this is about them and their life, and promote that choice. Okay, we're covering a range of topics, which are so important, all those circles, right? In the lives of our kids. Employment, the big picture. I'm not a guru on employment at all. It's such an area of need. I know there are a lot of great agencies out there and services. The big picture, though, I don't think this is anything new or people don't realize, but unemployment is quite high with our kids on the spectrum, or adults, I should say, young adults. They're employed at an alarmingly low rate. I don't know global estimates. I don't know if this is actually this range is accurate. I tend to believe so. Their employment is traditionally below their capabilities, and this has not significantly changed. Although there are movements towards better employment. Go ahead. I think vocational counseling and employment supports. Individual and group support models. I think in my mind, in my experience, there are more options for supports in high school for teens, even post-secondary and through state agencies, thankfully. I know that there's more, they have dedicated workshops and webinars that people are going to and brainstorming, and companies are starting to provide options for our young adults. But these are some of the models, internships. I have to plug up my own colleagues in MGH Aspire program. They offer wonderful internships that are supportive. They teach and train employers, because otherwise there's so many companies out there and so many private and public, and our guys are very capable and have a lot of skills. They just need the opportunity, and so we have to provide that. So I love the fact that we have individuals who know what autism is and who are advocates and go out and help create these Flutie enterprises and Spectrum careers. I don't know too much about what they're doing.
Why don't you include volunteer opportunities for these folks?
Thank you. I should have, and you know what? Shame on me. Volunteer opportunities, absolutely.
I don't know why that isn't pushed more, because it seems that employment seems like a lot of pressure on someone.
Competitive employment, even part-time, absolutely, thank you for doing
As a
that.
volunteer, they have more options and they're more likely to find something they really want to do. Maybe even like help other people with a disability even.
Absolutely.
Have that option.
I know many folks with whom I work who are volunteering at animal shelters or hospitals or nursing homes.
So much opportunity.
Right, thank you for that. I think we need to do more, and you know, it's great to get paid, you know, and even like the collaboratives, I know the lab collaborative and pays their students, you know, through their relationships with agencies in the community or jobs.
But
But
I think
it's
there's more of a
also-
limit in terms of what employment paid opportunities there are.
Right, no, I
for those
agree,
folks.
I agree. So then, state agencies, Mass Rehab and DDS, again, I can't speak to what they're doing. I know I did hear recently Mass Rehab is hiring more individuals, more staff to focus on our guys on the autism spectrum. So I know it's not perfect. I know that it sometimes depends on with whom you work, but we can't give up on it. We have to, you know, go with who's out there. I think DDS also is their new model of sort of autism only eligible. They're providing more coaching or funding for coaching because it's needed. So I think people need to think broadly and you know, again, it's our advocacy. It's parents and our kids that go to them to say, this is what I want. Vendor agencies statewide, I know there's a couple out here. There's we need more. Work Opportunities Unlimited is one that I know of. And Work Inc. Doing a great job. Capabilities on the Cape, there's many of them across the state. And then private coaches, I think we have to, again, you know, talking from an OPG perspective, I think coaching is the way to go. It's individualized and can be intense or can be, you know, different variations. But because our kids are different learners and slower learners and need so much, you know, direct teaching and coaching, I think that's something that our state needs to look at and try to cost share. All right, so some of the post-secondary educational opportunities, if you don't know about them, they have, you know, we have four-year colleges and universities, but our young adults may not be ready for that, you know. Many are and attempt it and either, you know, do well with the supports on campus or with private coaches. Some can't and fail, unfortunately, and come home and end up being, you know, on the couch or in the basement. And but we have to figure out a way to, I think, try to, you know, build a roadmap so that they can be successful. And maybe that's two-year institutions, community colleges. Maybe it's one class at a time. So there's no one size fits all here. I think we have to look for what's out there and provide these meaningful opportunities, even one step at a time. If our kids are, you know, motivated. Cooperative education programs, life skills programs, and volunteer opportunities. So again, this is not my niche, not my forte. I'm a generalist. I have to know a lot about a lot of things, but I don't hone in and I don't specialize in one area or another. Okay. Post-secondary education, I just said young adults with autism are less likely than any other disability group or group with disabilities to be enrolled in higher education. I think our state is doing better with different mandates for different opportunities on campuses. I just heard of a new program down at Massasoit in Brockton that for individuals who have intellectual disability to be allowed and be provided supported assistance on campus. And then we have the ICE programs and things like that. And I know AANE, which is the former Asperger's Association of New England, which is Asperger's Autism Network, has wonderful workshops every year, including panels of students who are in colleges and have been successful to share their experiences. And they also have life coaches who to talk about, or I should say college coaches to talk about different supports and services. All right, is this my slide too? Key points and summary of transition. Again, to optimize the functioning and outcomes, various areas need to be addressed. Family stress, education, vocational development, adaptive living skills, interfering behaviors, social and communication skills. I mean, the need for wraparound services, right, and supports, it's quite clear. Outcomes are generally disappointing, because of social isolation, interrupted education, unemployment, and lack of independent living. We're happy to hear that the State Department, DDS, Mass Rehab, and the private coaching opportunities are available, because I think this is going to change. I think when we do more, have more, the Aspire groups and groups through other agencies, and we can, I think, help our kids do better and function better. Again, lack of established services and supports and treatments and services. Adults with autism, if you're not tired, you're not doing it right. This is not from me, this is Peter Gerhardt, and I don't know if if you have heard him speak, but if you haven't, he's amazing. He's in New York or New Jersey, and he spoke last year at CTIA, Dr. Bowman's Current Trends in Autism. In fact, I think he speaks yearly. He's an amazing advocate and really gets adults. He actually befriends many adults. In fact, most of his friends are adults with autism, and he just is an amazing guy and a great advocate. We're talking about a lifelong condition, right? Lifelong. Given the striking increase in rates of diagnosis of autism in childhood, large numbers of youths with ASD are now transitioning. I think this is not a secret, we know this. These numbers are a little bit low. The department, we unfortunately in Massachusetts don't have the data. We don't have something in place to really know the numbers, but I think anecdotally we know there's several thousands a year aging into, across the state, aging into adult services, and that's only going to keep happening. So it's frightening to realize that we just need many more supports.
How do you spell Peter Gerhardt then?
Gerhardt is Gerhardt. Peter Gerhardt. You can Google him, you'll find him.
He's an advocate.
He's not, you can't hire him to be an advocate, but he is an amazing advocate for adults, and he knows a lot and can speak. I would go to see him and hear what he has to say, because he is very engaging and has a lot of great ideas. He actually co-runs a school in New York, and
What's the school?
Yeah. EPIC, E-P-I-C, yeah, sure. All right, as I had just said, adults with autism, here's where we don't need a specialist, we need a generalist. We need someone who knows what's out there, can act like a contractor, who's building a house, and get, subcontract, find people. We need, because there's so much to understand, from ABA to ed laws to civil rights to public benefits to employment to housing, mental health that we've heard a lot about today, and the medications, sexuality, systems of care, community-based programs. So if somebody in this room knows all about all those things, then I'd love to work with you, because that's a lot. So we have specialists out there, thankfully. Some of them are hard to get into. If Lurie Center, there's months, long wait list. But being a generalist, I think we need more of these folks. And, luckily these agencies, from Bridgewell to advocates and all these other agencies out there, Aspire, there's people that can do this.
Do you kind of address also the kind of, how the population tends to get stigmatized or marginalized? Which I think is a barrier for a lot of people with autism, and the stigma that they have to work with. I don't know if there's anything you can really do about it, but
yeah, I think the more aware, you mean out in the community, in life?
Yeah, I mean, I just think there's a stigma that they always have to, and I wonder if you address that at all.
Not specifically. I think we address bullying. I think people, and the isolation that a lot of our young kids feel because they don't have the skills, right? So I think the awareness, I would think people all agree the awareness of autism spectrum disorder is much more or greater now. Again, with more media, TV shows now, we see more, and so I'm thinking we're breaking through the stigma, but I don't know.
But I mean, maybe also for them to have, kind of learn the skill to advocate for themselves, if they are marginalized out there, which I'm sure happens.
Right. No, I think that's part of this. I think learning how to advocate. So it starts with self-awareness and acknowledgement, and I think that's hard for our guys to do.
Oh, yeah.
I want to keep going because we have a lot more slides to get. All right, not one size fits all. One of the major challenges in addressing transition is the tremendous heterogeneity of autism, and what causes it and the levels of cognitive adaptive functioning. I think that makes it challenging to create a transition plan and roadmap for all. We have to individualize it. Go ahead. All right, really quick. Actually, this is not really quick, but this is a case study. This is Mary. She's 21 years old, and she was diagnosed in the autism spectrum actually back in the day when it was PDD-NOS. And she had ABA, a lot of ABA, and learned rote skills. Not necessarily generalizable, but learned rote skills and a quick learner. She's also diagnosed with coexisting ADHD and anxiety disorder. That not early on in latency, but in adolescence, and she was treated and continues to be treated with psychopharm. She has average cognitive skills, so did well in school, average, needed support, always had a one-on-one in elementary school, but was in mainstream, and then needed to go to a collaborative from middle school on through high school. Social pragmatics, pre-voc, vocational assessments and goals. She had a lot of job exploration opportunities. I'm actually just summarizing this because I want to get to the where we're at now. She accepted a diploma. She had a 1 year post-secondary transition from age 18 to 19, which many of our young adult students are able to do now when you don't accept the diploma. But when you do accept the diploma, that usually goes away. It means you're done. You're done with special education. And hopefully you guys know this. Because the transition goals, which are the social, emotional, life skills, travel training, getting out to the community, vocational, independent living, those are all transition goals that really, if we advocate well, if someone earns a diploma, that's wonderful. That means that or pass MCAS, that means that they, do well academically, but everything else they still need work on. So Mary accepted her diploma because she wanted to celebrate and acknowledge and was very proud of that. But then she had no interest in attending college, and really when you leave school and special education, you have to rely on state agencies and DDS and mass rehab. And so who is going to get all that in place for Mary? And what was that going to look like? So there was and her area of vocational interest is food service. So she was able to luckily participate in an internship, volunteer through a local agency in food service. And then she was applied for and successfully hired 3 related food service jobs at competitive employment. But she didn't have job coaching on site. So because of her lack of executive functioning and her lack of perspective taking and her unable to realize that if I go and leave my job site when it wasn't break time, even though a lot of our kids are rule bound, this didn't pertain to Mary, impulsively went and did something against the rules and lost her job. That happened 3 different times. And again, because of the maladaptive behavior, she didn't have on-site supports. She has excellent self-care skills. She has excellent independent living skills around the house or in a familiar environment, but she has very difficult time sustaining attention, and she's very preoccupied internally. So, and she doesn't have any friends. I don't know if this sounds like anybody else that we know of. Difficulty lunching. She's back on the couch. struggling to get off her iPad, to get off, she's on social media, and by the way, learning about what's out there, in the relationship world, because it's easier, it's not in her face, it's here, which is very scary. So, has an outpatient therapist, has done a couple of groups through Aspire, which has been amazing, but they're short-term, and she's eligible for SSI and DDS, so, and covered under her parents' private insurance. I don't have an answer. It's a struggle. It's definitely, this is going to be a marathon and a lifelong situation. She's 21. She wants to work. She wants to have meaningful activity and work in food service. I think the next thing is we're going to hopefully work with another life coach and try to create some goals and get her back out, because we can't give up. All right. I think we already talked about this one, so we're just gonna, all right, adaptive behavior. Real life and teaching essential skills. A skill that is used frequently and when acquired allows the person to independently complete a variety of tasks and engage in desired activities. Reading, toileting, personal hygiene, making a meal. What you do every day matters more than what you do once in a while. This is Gretchen Rubin. We're talking about adaptive behavior. That's really innately what our kids struggle with, and if they can learn it, but it's generalizing it. That's the problem. All right. Social skills training for individuals on the autism spectrum, absolutely. There's different, comprehensive assessment. We really can't create goals without an assessment. We need a starting point. We need perspective taking, self-awareness, executive functioning. Sensory, a lot of our individuals difficulty with sensory processing. Do we do individual, dyads, groups, all of the above? They're all important and at different times, I think. Do we do office-based, or we do real life out there in the community? I think natural settings are really important. If your young adult is not accessing the community and socializing, why do it? Why have the service in an office? Out in the community is the best way to go, and I think some of our coaching programs allow that and do that. I know that Aspire offers those types of activities as well as other agencies. The 3 S's: social competence, self-awareness, stress management. Self-management must teach individuals with autism to self-manage and self-reinforce. Self-reinforce, it's lifelong learning for all these issues. Problem solving, initiative, productivity. You want to keep going? There you are.
All right, so I'm going to just touch upon autism and sexuality. This is very important, something that should start at a very, very young age. Sexuality is generally difficult to talk about in an open and honest manner, but sex and sexuality are central to our understanding of ourselves as individuals, it's a part of quality of life. So this should start at a young age, like I said, just the differences between boys and girls, using the boys' room versus the girls' room, just dating in general, and then up to, marriage. This is also huge in just safety skills for individuals with autism. Sexuality instruction focuses first and foremost on personal safety and self-knowledge. While sexuality education may be both frightening and complex, it should be considered an integral element of a comprehensive transition plan, assuming that the goal of such is to plan an education is to be safe, competent, and confident adults. Like I said, this is something that should really start at a young age. Sexuality education starts very early in life and continues through adulthood. Sex education consists of instruction of 3 content areas that are most important. So basic facts and personal safety, individual values, and social competence. Oops, I'm going to go back again, sorry. So just basic safety skills should be considered both necessary and appropriate for individuals on the autism spectrum. Sexuality is generally ignored as it pertains to learners with ASD until it becomes a problem, at which point we generally regard it becomes a big problem. So this is just a quote that we have found. So sexuality education with learners with ASD is often regarded as a problem because it is not an issue, or it is an issue because it is seen as a problem. So some key points. Major preparation is key to sex education. So number one, start early. So TEACH, which is the treatment and education of autistic and communication-related handicapped children, suggests that parents and professionals begin discussing sexuality around the age of 10, 2 to 3 years before the child enters puberty. You can even start earlier than that. Individuals with autism are very resistant to change, as we know, so it is important to give them plenty of time, plenty of notice regarding what change will happen to their bodies in adolescent and adulthood. You should teach them about these changes long before they occur, so preparation is key. Be clear and direct. So clear and direct education is essential, and a development approach is the most effective when teaching sex education to young adults with autism. Each skill and behavior should be taught as a series of developmental sequences or hierarchies in event which can be analyzed and broken down into several levels. So here's kind of an example of just a roadmap. And in working with kids with autism, it needs to be clear, direct, and as simple as possible. So a girl meets a boy. A girl and a boy start to say hi to one another. A girl and a boy keep talking as friends. A girl and a boy start to spend more time together. A boy and a girl may go to the movies. A girl and a boy may hold hands. So it kind of just gives you a roadmap, and it can continue all the way to marriage, family, and adulthood. So this is also another quote from Adolescents Without a Roadmap from Claire, from a family. For a long time, our son was a little boy with autism, which was a certain kind of challenge. Now he's a teenager with autism and a teenager who notices girls. Now we're faced with something else altogether. So just some advice for parents. Before you can effectively communicate your values about sexuality to your children, you need to know what you believe and why. That's really important that you know and discuss this before talking to it with your children. You are the main educator of sex for your son and or daughter, so whether you are comfortable with it or not, wouldn't you rather them get the information from you versus somebody else, a classmate, a friend? So you must be askable. This means you should be prepared for any question or incident that involves your son or daughter's sexuality. And make sure you let them ask you anything. You need to be open. You want to be the ones that are teaching them. Always say that's a good question. You can decide to answer the question immediately, or you can say we'll discuss it when we get home. If you answer it with a positive tone, then your child will continue to ask questions. Also remember to answer the questions simply and directly. Children are not perfect. They do make mistakes, and it's up to you to turn their mistakes into lessons. And I think this is definitely one of the most important pieces of this, is remember to use the same teaching strategies that you have used to teach your children other skills. So just because it's sexuality, don't look at it any differently. Teach them how you've taught them to do anything else. Some of these strategies may include visual schedules, check-off lists, videos, facts and books, pictures of what is happening to their bodies, stories to predict what might occur. Think of puberty as just another stage of development. Prevention of abuse. So the concept of appropriateness when it comes to relationships is critical in sex education in order to prevent abuse. Unfortunately, with a lack of knowledge about inappropriateness and abuse, individuals with developmental disabilities are more likely to be victims of sexual abuse. So according to Dr. Nichols, individuals with autism are extra vulnerable due to difficulties recognizing the red flags and just social cues in general, and are interrupting thoughts, feelings, and behaviors of others. It is essential for young adults with autism to understand what types of behaviors are appropriate and what's not. So this is another quote from Dr. Peter Gearhart. The true issue is prevention of abuse, not pregnancy. So it comes down to education direct to personal and sexual safety, starting with closing and locking the bathroom doors, knowing who can and can't help with menstrual care, and understanding the difference between good touching and bad touching. So this is just an example, a case study, and I'll try to go through quickly, just of the importance of sex education and how it affected this individual and their family. So Ben is a 21-year-old male diagnosed by a provider with ASD at the age of 5. He was also diagnosed with an unspecified mood disorder when he was 9. His father was never part of his life, and his mother had passed away when he was 7 due to an overdose. His mother came from a political family, and so he currently lived with his aunt, who is mainly raising him since birth due to his mother's addiction. His aunt is very dedicated in finding him the appropriate care that he needs, despite his diagnosis and losses. He's high functioning, intelligent, has great self-care skills, but does lack his social skills and executive functioning. He has a lot of difficulty just understanding social situations and social cues from others. He received ABA services at a young age, tried various special academic institutions through middle school, and attended his local public high school with his typical peers until high school. So during high school, he attended a specialized day program and did some social skills groups outside of school. He did receive his high school diploma, and he attended 2 years of a specialized college for individuals with learning disabilities and did independently live on campus. He completed his second year of college and had a GPA of a 3.4. So Ben possibly had an obsession and an addiction in buying political gear from presidents. So when eBay started to decline as a resource, he began expanding his internet